My role in this talk is to take your attention to the healing reactions, how we succeeded in, especially in endovascular treatment. And these are my disclosures. And let me start with what is our aim. We should not forget it. Our aim is to take off the pressure gradient across the disease wall of the sac and neck. And the aim is enhancing healing reactions to prevent rupture or regrowth. We should not forget this. If you follow your patient long enough, every one of you will observe such results. This is a simple conventional coiling treatment with balloon remodeling. This is a 1-year follow-up, even with the white nag on the right. When you look at the 6-year follow-up, you may see such problems. And that maybe this is clinically silent. And then when you look at the bunch of papers on the regrowth, and then whenever the aneurysm size is going bigger, that the regrowth rate is also, the numbers getting bigger. And of course, most of them, the follow-ups duration is not such long. But for your attention, I would like to give some slides on the ICENS, because it is follow-ups goes up to 18 years for that certain group. And then the primary outcome in a 1 year, as we all know, is quite good enough to enhance the endovascular treatment. And then but are these coiling and cleaving durable? Yes, they are. When you look at that and disability scores, both is fine. But this paper doesn't show that tiny morphological change, and then doesn't show us that details, especially in certain aneurysm, such as the aim in this type of aneurysm, in most of us that doing a morphological treatment, that means a psychocclusion with something, that we are very, very successful on it. This is a total eradication of the sac and the vascularly. When the 1-year follow-up looks really normal, look at the P1 on the right and the P1 on the left. But when you look at the 5-year follow-up, the sac is still not filling, but that the P1, the first segment on the left side, is getting a fusiform shape. That means, hemodynamically speaking, there is a hemodynamic change here by changing the artery itself. That means disease is going on there. Because in the bifurcation especially, we didn't change the constant hemodynamic stress there. If the vessel wall is diseased, that is continuing on. That's why in early 2000 or before 2000, our attention shifted to the lumen, to the vessel wall, especially in such type of aneurysm. And we are shifting our attention to the real healing reactions from the dog ears, starting from the dog ears, and we start to understand the power of hemodynamic and how we do it. This power of hemodynamic and helping the healing reaction. An example, it's 2001, aneurysm, bifurcation, prone to re-rupture, and embedded in the diencephalon, partially thrombosed, all morphological features prone to re-rupture. And I did the coronary stent placement at the neck and the onyx in the sac. And look at the follow-up, 6-month follow-up. And there is a total eradication of the sac with a nice intimal reaction between stent and then the material itself. And then when you look at the first year follow-up, clinically and morphologically, patient is in perfect condition. This is the 18 years of follow-up also showing that the correction of the pathology in that specific region. Let me give you a very nice example. This case is clearly showing the history of the endovascular treatment. When I first started to treat this patient, it was 1996. This aneurysm, mid-basilar aneurysm, ruptured, already have a failed surgery. And 5 days later, he came to us with an enlargement. And this time in 1996, the simple coiling and total eradication of the aneurysm. That's okay. And look at it. As a 9 months later, regrowth in 1997, and then we got the one of the first balloon remodeling case, and then the balloon showing us simply that the the aneurysm is located in the fenestration leg. Look at the dumbbell shape of the balloon. This time, again, that the narrow neck, circular filling of the aneurysm is eradicated with this technique. This technique was the best because we are always having a new technique, new technology, but how this new technology affects our approach. And then 3 years later, after second treatment, stable occlusion, we are all happy. And let's follow more. 5 years after the second treatment, there is a concavity here. There's an indentation of the coil. Look at this. In 2007, 10 years after the second treatment, there's an obvious regrowth with a multilobulated fashion. This time, again, I did the balloon remodeling technique and coil every part of the saccules. And then to enhance the healing reaction, I deploy a stent there. These are the new regrowth sacs. This is the third treatment, and that time, this is one of the best treatment in our hands. And with the new technology, the neurovascular stent, we get rid of the coronary stent at those time. And this is the history of that, the 1996 ruptured coil and regrowth, balloon remodeling and coil and regrowth 10 years later, and additional stent. And another 10 years passed, and another regrowth. 10 years after the third human regrowth, and look at the morphology. The morphology doesn't look a simple saccular aneurysm anymore. It looks like a dissecting aneurysm, but remember, it was a saccular aneurysm at the beginning. Even more surprising figures of this case, that stent is also ruptured by the power of the hemodynamic. And what we're doing here, we are treating our patient with our best material. And 2017, what is our best material in those situations is the flow diversion. And I did the flow diverter, corrected the stent, and this is the 1 year follow-up of the third treatment with the flow diverter, and the vascularly looks normal. And then 1.5 years later, IV was CT, also looks okay. And this is the almost 4 year follow-up of this particular case, also looks okay. Is that the end of the story? I don't think so. Why? The same location, blister aneurysm, ruptured, coiled with the balloon remodeling technique, waiting for stent, because this is the blister aneurysm, we believe stent. And 2 weeks later, look at the regrowth rate, how fast it is. And this time, another balloon remodeling technique, coiling the sac and dumb, and this is the flow diverter in the basilar artery. This is the one of the best, strongest treatment what we have. Follow this case. 2 months later, just 2 months later, guys, look at the big regrowth and then the coil shape, even with the flow diverter treatment. And we have a success? No. When you look the filling portion of the coil, very tiny. This is the jet flow, very tiny. How that flow diverter doesn't work in that location? It is interesting. And telescopically put another pipeline, we had no other options, and fortunately, that second flow diverter worked. And 3 months later, aneurysm had a stagnation and then shrinking. That means that shrinking means that healing reactions. It looks like a wound at the skin, guys, that the process in the vessels almost the same. If you have a shrinkage of the aneurysm, that means you have a very nice, powerful, the features of the healing reactions. This is a 2 years follow-up. Look at the coil is just everything, the stent system, telescopic stent system, and patient is fine. And another morphological things is the intimal reaction, because the body is producing the collagen, and the myofibroblast is very main factor for healing reaction. In 2000, I was using the coronary stent in such location. This is the real PCOM aneurysm. Look at the flow in the distal on the left side, presented with the anterior thalamic artery infarction. And immediately after one coronary stent, the flow hemodynamically rapidly changed, and I put one coil at the orifice of the PCOM. That's it. And look at the follow-up. 6 months, 1 year, and 5 year follow-up clearly show that intimal reaction in the stented segment and the eradication of the aneurysm sac from the circulation and shrinking of the aneurysm by time and remodeling of the intimal reaction by time. That is the normal reactions of the body. Only thing we didn't aware and we didn't control how the intimal reaction size, intimal reactions amount, and the volume. And this is 12 years follow-up of this case, also showing the stable occlusion and eradication of the aneurysm sac. We're not seeing the aneurysm sac there. All the sac is that shrink. That is very important. The MRI is a very powerful tool to check that unfeeling part of the aneurysm, especially for giant and very large aneurysm. This is very typical indication for flow diverter. Now, flow diverter, our tools are we are very proud of it. Is that so? Yes, but I'm really have some questions on those. Let me show you some example. This is very simple procedure to put the silk and the stagnation of the lobules at the same time. And this is the follow-up. What we're seeing in the follow-up, first, we got our aim. We eradicate the aneurysm. By what? By having this stenosis here, fish mounting in the stent, and then the very clear visibility of the intimal reactions. Yes, we already know that intimal reaction is a feature of the healing, but what about this fish mounting? And what about the stenosis? This is the situation creating the parent arterial occlusion without our knowledge, because we didn't check our patients every day or every week. This is a year follow-up. I just continue on a double anti-aggregation. I didn't touch this patient. I didn't do angioplasty. This is a spontaneous resolution of the intimal hyperplasia. I already know this feature from the body healing or from the previous experience with the coronary stent. Without touching it, spontaneous resolution of the intimal hyperplasia and fish mounting means that the healing reactions, the vessel wall in the vicinity of the aneurysm is very important. Because of the braiding technology, stents can able to change their shape because the external force is actually the vessel wall, which is actually over-supported by the intimal collagen level, because the stent itself is jailed between the intima and the vessel wall structures and need to follow this vessel wall diameter. This is the 7-year follow-up, this particular case, also showing the stability of everything. It did, and after resolution of the intimal reactions and the shape of the parent artery vessel, you may change your anti-aggregant protocols. How can we control that intimal reactions? How can we see it? Yeah, we have tools in the radiological things, but that's something coming for us. I'm very excited about that. That is actually optical coherence tomography, or CT, and then first starting in Japanese, now enhancing more. We can check the position of the stent or the material. We can check the early thrombosis on the matter or intimal reactions, side branch orifice. But more importantly, when and how to perform the follow-up imaging is still a debate, big debate. When and how to reschedule our anti-aggregation protocol is so we are debating a lot. These type of images is very important. The problem of this technology is the penetration of this technology is very low, but the resolution is very high. It is showing down to 10 micrometer structures in the vessel wall. Even the thrombosis, intima formation orifice is clearly visible. For the maximum diameter of the parent vessel is 4 and 5 millimeter. More than that, because of the penetration, you cannot see that. And also the rigidity of the catheters is another important profile is getting reduced. As far as I know, it's go down to 4F. I believe we need more flexible material to see it. Another example for intimal reactions, ruptured aneurysm, and then clipped with an open surgery. And 10 years later, there is an obvious regrowth. This is an example for failure of the open surgery. And then the anchoring and looping technique of the flow diverter. This is the aneurysm itself and clip. Look at the follow-up. Headache, only headache 3 months later, and aneurysm is gone with an intense intimal reactions. That is the body is doing. When you have a giant aneurysm, you are seeing such things. After angioplasty, we maintain the flow, but we have to be vigilant to observe these cases. If you want to increase the healing reactions, we need to know how to follow those cases. This is a 1.5 year later after angioplasty. Again, the body did this job, resolution of the intimal reaction without any problem. This case also showing very nice wall healing and effect of the flow diverter, this dissecting petrocavernous segment aneurysm. Please have a look at the shape of the flow diverter at the 4th month. After occlusion, region of the aneurysm sac, spontaneous normalization of the internal carotid artery diameter and the stent morphology. Don't forget, this is the braided stent, they're following the wall. An intimal reaction is gone by time. And I also published this by attaching that the hypersensitivity to the metal body, because everybody is reaching the certain reaction by itself, and every stent showing the same morphology. Even with the chrome cobalt based pipeline is doing the same fish mounting effect. Silk, Ferrari, and others also. Do we have a perfect healing reactions in with the flow diverter? This case, the rupture PCA aneurysm had 4 stents, guys, 4 stents in different years. And 4 years later than the second treatment, no change at all. No aspirin, no Plavix. Where is the healing reactions? We should not forget that even we are doing a 4 telescopic stent, we may not enhance the healing reactions in certain cases. That means you cannot generalize everything to every population. Only in the 6-year follow-up, without any aggregation, we start to have some hemodynamic thrombosis and healing process. And the last 2 cases, and I will finish my talk. This is a simple petrocavernous aneurysm presented with the pain and ophthalmoplegia, telescopic Leo and Silk, without changing anything. And then the second Silk deployed in 1.5 years later and start having thrombosis. But still have some problem here. And then the 2.5 years later than second treatment, look at how changed that, how onion shape enlargement of that giant aneurysm and creating the edema in the temporal lobe. And this is the aneurysm feeling. This is the aneurysm. It is growing, guys. Even we have a three stent. And then we decided to put another flow diverter at that time. And this is the after flow diverter MR control, edema is gone, inhomogeneity in the aneurysm. But 3 months later, aneurysm is still feeling. And a year later, aneurysms start to grow again. And here, aneurysms start to grow again with the same jet flow as I showed you in the mid-basilar segment ballister aneurysm. We did 4 stent there, but we didn't have a success. And then I decided to do the parent arterial occlusion. And then after parent arterial occlusion, edema is gone. And then this is the situation. And this is 1 year later. And this is the 3 years later after the parent arterial occlusion. I still didn't like this aneurysm because of this inhomogeneity in the aneurysm, and it didn't shrink at all. Yes, I stopped the growing, but I'm not trusting that vasovasorum and subadventitial factors may create certain aneurysmal growing and certain problems. And this is very important. And last factors, we should not forget that healing reaction need thrombosis, stagnation, and inflammation. That inflammation may create rupture in certain case. Even with a very successful diverter treatment with the serpentine type of human here and a nice thrombosis started in the aneurysm, we may have a rupture because we are not controlling the healing reaction by doing simple flow diversion technology. For future aims, so we need to focus on the control healing reaction at the aneurysm neck and at the same time the vessel wall which aneurysm has. We need to reduce or optimize the body reaction on the metal. Now we're having surface technology. You may listen in the next talk. But what is the optimization? Do we know what is the optimized body reaction on the metal on a certain segment of the cerebral vasculature? And eliminating the vascular mass is very important. Most of the aneurysm, by luckily, they are eliminating by themselves. But some of them, especially giant one, is not. So we need to focus on vasovasorum in that case. Maybe we need to have additional supplementary surgery to eradicate the vasovasorum and the mass, especially if the location is feasible for it. And I would like to thank you for your kind invitation and for attention. Thanks.